Hi there and welcome. My name is Dr. Marlena Jabara, and I'm the proud founder of RadPodSquad. The RadPodSquad Fellowship offers an immersive learning experience tailored specifically to podiatric imaging. RadPodSquad combines comprehensive curricula, cutting-edge techniques, and on-demand access to training that will provide you with the new knowledge and skills that you need to boost your confidence in imaging and truly make a difference in treating your patients. Check us out today, radpodsquad.com. Moving on to concepts of pronation or supination. Excessive or prolonged pronation or supination can contribute to overuse injuries. The subtalar joint allows the foot to make stable contact with the ground and get us into that weight-bearing position. If we have excessive motion, it really is compensating for our structural deformities that are existing. Structural deformities are going to include forefoot and rear foot varus. They can be associated usually with overpronation. Forefoot valgus can cause an excessive supination and may actually interfere with shock absorption. When we think about excessive pronation from the neutral axis, let's take a look at the fibula, the tibia, the talus, and the calcaneus, all in neutral positioning. What happens in excessive pronation is that there's an internal rotation of the tibia such that the driving force pushes the calcaneus away from the body. So a pronated stance are a major cause of stress injuries due to overload of structures during extensive stance phase or into that propulsive phase. This can result in a loose foot, allowing for more midfoot motion, compromising that first ray and the attachments of the pronatus longus as there's more instability during this time. There could be a negative effect on the pulley system of the cuboid relative to the peroneal, decreasing again stability at the first ray. All of this excessive pronation can cause more pressure on the metatarsals and increase in that tibial rotation. And it will not allow the foot to resupinate to provide that rigid lever so it's less stable, less powerful, and even less efficient in that it's toeing off on a greater surface area and not really concentrated at the great toe. What happens in these patients? They can also get second metatarsal stress fractures as they load the medial forefoot and plantar fasciitis. Different complications including posterior tibial tendinitis, Achilles tendinitis, tibial stress syndromes, and medial knee pain are associated with these patients who have excessive pronation. When we think about excessive pronation, we're really in the game, I think, of pes plano valgus. So that's really a flat foot, hind foot adaptive mechanism. And this is another great slide that shows us some features of this adaptive mechanism in a flat foot. So in a normal situation, you have an arch, and when you lose that plantar arch and you begin to have declination of the talus, you have this medial column elongation. Now we know that the lateral column is relatively fixed. There's not a lot of mobility between the calcaneal cuboid and the fourth and fifth. What happens is that the place that it can move is along the medial aspect of the foot, and there's this dynamic motion and rotating around the lateral column. What's going to occur is that overpronation and hindfoot valgus that will occur here in these patients, where you can see in this case some uncovering of the talar head in a patient who has excessive pes plano valgus. Now, in the contrast to that, let's talk about excessive supination. This is where we can cause the foot to remain rigid, decreasing the mobility of that calcaneal cuboid joint and the cuboid itself. This results in increased tension along the pronatus longus and decreased mobility of the first ray because the pronatus longus can no longer effectively act on it. This will decrease your ability to absorb forces around the first and the fifth, very important. So these metatarsals and their inefficient ground reactive force absorption limits internal rotation and can lead to a series of sprains and repeated tibial considerations. We get complications such as stress syndromes along the fifth ray, peroneal tendinitis, and even all the way up the chain to iliotibial band friction syndrome and trochanteric bursitis. What we're seeing in the illustration, the lateral side of the ankle, the medial side of the ankle, the talus, and the calcaneus, a neutral vector that we're seeing here, is that we're having an external rotation of the tibia in these patients that are having this varus biomechanic. This external rotation will create that bow-legged appearance. Notice also that the calcaneus is moving towards the midline, and we have the bowing at the lateral aspect of the calcaneus. Hindfoot adaptive mechanisms in patients who have pes cavo varus can be seen when we have a normal arch and it actually increases. And so what's occurring here is medial column shortening. Now, as we mentioned before, the lateral column is relatively static. There's not a lot of motion between the calcaneus, cuboid, and base of fourth and fifth. So all the motion is going to be along the medial column, and the dynamic changes that occur in a clockwise fashion rotate around the lateral column and create a situation where we're going to have a hindfoot varus and drive the first ray to the ground. We can increase our pronation moment by stressing the metatarsals and putting them into a metatarsus adductus. Once we fail that type of biomechanic, we begin to have stress fractures in those regions, and you can see that here. Are you ready to take your podiatric imaging skills to new heights? Check us out at RadPodSquad.com. Explore our online learning community, and don't forget to like and subscribe to our YouTube channel for more enriching content.